As you probably know, these mesenchymal stem cells, which some people argue aren't even actual stem cells, they're more like messaging cells. What they're doing in your body is they're not, when we give them to you, they're not engrafting in general and changing into other types of tissue. In the old days, we used to think because they do this in a petri dish, they can become different types of tissue, they can differentiate. That's one of the signs of a stem cell. We assumed that that's how they were working in the body. If we took stem cells out of your fat and we put it in your joint, they must be becoming joint tissue. That are they turning into cartilage? Are they turning into ligaments? Like, what's happening? But what has been found is that these cells, whether you call them stem cells or not, are actually signaling the tissue that's already there.
Welcome back to the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. My name is Dr. Scott Sher, and I'll be your host today. It's so nice to be back with all of you. Before I get started, don't forget to like and subscribe below so you don't miss an episode. I had a great time this time interviewing one of good friends of mine, Dr. Amy Killen. Dr. Amy is a leading anti-aging and regenerative physician. She's board certified ER, and she was in the ER working for 7 years until she saw the effects of unchecked chronic disease and decided to transition into anti-aging and longevity medicine. She's an international speaker, a clinical practice owner, entrepreneur, author, and frequent media guest. She's also an outspoken advocate for empowering people to look and feel their best by merging lifestyle modification, integrative medicine, bioidentical hormones, nutritional supplements, energy modalities, and stem cell therapies. In Dr. Amy's clinical practice, along with Dr. Harry Adelson, she pioneered with him the full body stem cell makeover, one of the most innovative regenerative procedures currently available. In her portion, Dr. Killen combines stem cell injections with light, sound, and other energy-based therapies to give patients unparalleled synergistic regenerative effects for skin, hair, and sexual systems. And we talk about this during the podcast. In addition, Dr. Killen is also the founder of Hopbox, or Human Optimization Product, a dynamic monthly subscription for longevity supplements and educational platform as well. So Dr. Amy and I, we had a great time on this podcast. We started off talking about her work with Dr. Adelson and stem cell makeovers. We talked about different types of stem cells that are being used in this country and other countries around the world. Then we transitioned over to speak about ovarian aging. We talked about aging as a disease. We talked about ovarian aging and menopause as a disease as well. We then transitioned over to hormone replacement therapy, both for females as well as for men. We talked about testosterone for females and how even if you've had breast cancer in the past, maybe testosterone might be helpful for some women in menopause, which is super interesting to me. We then transitioned over to Amy's framework and how she thinks about sex and sex exponential medicine that she talks about a lot. And then we dug into nitric oxide. We talked about Amy's 3 things that she would recommend doing to live smarter, not harder. I hope you enjoyed this episode. It was a lot of fun to record with Amy. She's fantastic. If you have any questions or concerns, leave them in the comments. We like to read those as we can. And this episode is brought to you by both Transcriptions, makers of precision dose, pharmaceutical grade, and physician formulated buccal troches, as well as Health Optimization Medicine and Practice, a nonprofit organization training doctors and practitioners on how to optimize health rather than treat disease. Enjoy the episode. Take care. How are you?
I'm great. How are you?
It's good to see you again. It's been a while.
It has been a while. But it's always fun to talk to you.
I'm always amazed when I see you at conferences and you're always so much taller than I think you're going to be.
I just keep growing every year.
It must be all those stem cells that you're using or taking or putting in people. I don't know. You're taking some for yourself. So I think today you're actually at the stem cell clinic. Is that right?
I am. I'm here in Park City. I just had a case. I almost didn't make it done by this time, but I did. So we're good.
Nice. And so this is the full body stem cell makeover?
Yes, exactly.
So this is with you and Dr. Harry Adelson then, yes?
It is, yes.
Yes. And so how long you guys been doing these now?
I think it's been like 4 years, maybe about 3 or 4 years that we've been doing this big procedure. I've worked with him now for about 8 years doing stem cell procedures. And, he does musculoskeletal, so neck, back, joints, and I do sex and skin, I say. So aesthetics and hair restoration, and then the sexual injections as well. So we work together on these big cases and kind of just do the whole thing.
Right. So, and the process here, I know you've spoken about this on podcasts, but just to kind of do a quick overview, you're using bone marrow derived stem cells. Is that what Harry's doing? Is he taking out from the bone marrow? What are you guys doing?
So we actually have a few different options now. This is pretty new. So we have the autologous option, which is going to be bone marrow and fat. If you have fat, bone marrow and fat from the patient. And we add a little PRP in there as well.
Sure.
And that's the one we've been doing for 4 years or so. And we have the most experience with that. But recently, 6 months or so ago, we started actually offering an allogeneic option where we're using placental derived, growth factors and exosomes and Wharton's jelly and some of the placental biologics, and instead of the autologous. And so we've been doing that for about 6 months as an option, and people are loving it because there's so much less downtime. You don't have to do a bone marrow aspiration and a fat aspiration, and you don't have soreness and all of that from that. So we have both of those options going these days.
Interesting. So then this kind of puts up a really interesting question. A couple of them for me. The first one, I guess, would be, you're the sex and skin goddess, right? The doctor goddess, Dr. Amy. And like, could you have ever imagined in the emergency room when you were putting needles in people's backs to actually think about doing anything with what you're doing now?
Oh my gosh, I had no idea at all. It's funny because I used to see, we used to see like urologic emergencies. So we'd see like priapism.
Priapism, yes.
And the treatment, ultimately, if the medications don't work, is you get to put a needle in the penis and you have to pull out the blood. And although we were just told, call the urologist, they'll do it. But I remember several times, it was like middle of the night, this would come in and we would do the medication, the Sudafed or whatever. And I was just like praying it would work because I was terrified of the idea of putting a needle in someone's penis. And now it's like every day,
what you do for a living.
And I'm just like, where are my needles?
How many needles can I get in the penis today?
Exactly. So yeah, it's funny because I just never thought I would do it. But what happened was I left the ER about 10 years ago now.
Right.
It's been 10 years. And I started seeing hormone patients and doing lifestyle stuff and, just kind of trying to help that way. And people would, after they started kind of feeling a little bit better from the hormones and they're motivated, they're losing weight and all of those things, they would come back and they would always ask me for help with one of two things. Can you help with my skin and hair? Can you help me look better? And can you help with my sex life? And so I was getting those questions so often that I realized that there must be a way to approach those from this sort of integrative medicine, regenerative medicine standpoint that wasn't really being talked about.
Sure.
And so that's kind of how I got into it. So skin and sex, they don't seem to go together, but in my world, they do. That's
you. Obviously you didn't plan this, right? It wasn't like you're in the emergency room thinking about, being the sex and skin sexponential medicine doctor that you are now. So, and by the way, Amy is in her office and she has a real-time, anesthesiologist behind her.
There he is.
So, real time. So Amy's a real doctor. She doesn't play with just one on TV or on a stage. And, that's the other thing that Amy and I were talking about actually before we got on the podcast is that, when clinicians stop practicing, even if they're just talking all the time, if they're writing books and doing lectures, they could be very smart and very brilliant at what they do. But it does, you do lose a little bit of an edge, I think. And so this is something that, I just kind of, I say it out loud to people that are listening, and just in the sense of, if you're listening to advice from people that don't see patients, that don't have a clinic that they work with, this could be your influencers as well, ladies and gentlemen. Like, just be aware that what they're doing is maybe working for them and maybe like a very, very small subset of people, but this is not something that probably is going to be the right answer for you most of the time. And sorry, it's my soapbox, Amy, but the other piece of this is like a lot of very prominent researchers right now with millions of followers and the most amazing podcasts and great information, but they don't see patients. Okay. And so I don't know if you feel the same way as I do about this.
I totally do. And, I think it's that. And it's also, I know of some doctors who have, the doctor names after their degrees, but they've actually never seen patients. Like, they maybe went to medical school and then they left and then they're out doing, and again, very smart people have some important things to say. However, if you never spent, your internship and residency and preferably some extra years after that, seeing patients, I think that's difficult. And one of the things that I think has happened, especially in this in like the wellness world, where you and I kind of dabble, like you and I both kind of like, we're like on this like bridge, like trying to like bridge medicine with wellness, I feel like, right? Yes, and I feel like a lot of the people in the wellness world, they're very like hostile towards traditional doctors.
Yeah.
They dismiss them. They're stupid. They don't know anything. They're doing it all wrong. Like, they're so dismissive. And I get very angry because, to me, unless you have worked in a hospital setting with chronically ill patients who are, and not getting paid well and having to rush and like all the things that go with being a traditional doctor, then you have no idea. And it's easy for you to like be on your like little soapbox in your
Yep.
house making
Your high
videos.
horse.
But
Yeah.
that's a whole different ballgame. Sorry, I have my own soapbox, it turns out.
Yeah. So it's interesting, right? Because I often say that it's in this world of wellness that you and I kind of dovetail in, like with the conventional side and then the alternative or integrative, whatever you want to call it. It's almost easier not to have a license in some ways because like these guys don't have, and women don't have any recourse. Like they can just pick up and change their name and they're good. But we have licenses to actually keep and to maintain. So, but at the same time, I agree with you. I think that there's a lot of smart people in the community, and I think you and I both agree with that. But I think if it's not a zero sum game, and I think I have the story of like my father is a good one. He's a chiropractor, right? He was militant against like the medical industrial complex back in the 1980s, but now like and he sends people to the hospital all the time. He knows that there is a middle ground for people. The soapbox is real, right? We both have a soapbox, and I think that we just kind of try to dovetail these worlds of conventional and sort of integrative medicine, but when you're taking advice, just be aware of who you're taking advice from. I think that's the end result, right?
Exactly. Yes. Love it.
Yeah. So back to stem cells, because let's go through that, because I think it's super interesting that you guys are now using this Wharton's jelly, this placental, these placental tissues. There's all these different types of stem cells available, right? So there's the bone marrow derived, there's fat derived, there's growth factors from the placenta, there's Wharton's jelly, there's umbilical, which you can't get in the U.S. There's exosomes, which I don't think you can get anymore in the U.S.
You can still get them. Yes, you can. I mean, there's a lot of the FDA has not approved a lot of these therapies in the U.S. There's some of these products that are, more like tissue bank products that are not officially approved to treat any specific disease. And so you can't make claims about saying, I'm going to cure your Alzheimer's or I'm going to cure your, Parkinson's or things like that. So you definitely can't do that. But some of these products are still out there and are still, great products.
Okay. So, so when it comes to different types of stem cells available, it sounds like you can still get exosomes. What would you say is sort of like the sort of ranking of what you think? Are there various types of stem cells that we use for different types of places? It sounds like you're using, maybe a certain type for sex and skin, a certain type for muscle tissue. Like how does that break down typically?
So right now we're just mostly using the same types for all the things. That is definitely something that is coming. A lot of the different research labs are working on developing different lines of stem cells as well as exosomes and growth factors which are coming from stem cells that are specific for different conditions or different parts of the body. So you'd have different stem cells for hair restoration than you would, for treat spinal cord injury or whatever. That's certainly being researched right now. I think we'll definitely have some products in the next few years that we can use. But right now we're just using just mesenchymal stem cells that have this, either placental derived or autologous from the patient, because they still have the ability to do a lot of different things in the body. And as you probably know, these mesenchymal stem cells, which are not, so some people argue aren't even actual stem cells, they're more like messaging cells. But what they're doing in your body is they're not, when we give them to you, they're not engrafting in general and changing into other types of tissue. So that's in the old days, we used to think because they do this in a petri dish, they can become different types of tissue. They can differentiate. That's one of the signs of a stem cell. We assumed that that's how they were working in the body. If we took stem cells out of your fat and we put it in your joint, they must be becoming joint tissue. That are they turning into cartilage? Are they turning into ligaments? Like what's happening? But what has been found is that these cells, whether you call them stem cells or not, are actually signaling the tissue that's already there. So they're essentially signaling that joint tissue and saying, hey, we actually need to repair, we need to become more active, we need to increase blood vessel formation, we need to, it's essentially getting your own stem cells that are already in that tissue or tissue bed to become more active and to act like more youthful tissue. So that's how they're working. So they're really signaling more than they are differentiating and turning into a different tissue. So that's why we can still use, that's one of the reasons we can still use just sort of general mesenchymal stem cells, because we know that they all have these similar properties, which is, they're going to increase angiogenesis, you're going to have improved blood flow, you're going to decrease inflammation, or at least, modulate the immune response up or down, kind of depending on what's needed. You're going to have some antimicrobial properties, you're going to have some regenerative properties. So they have all of these stem cells, these mesenchymal stem cells, they do these sort of 5 or 6 same things, no matter where you put them. But it turns out that those qualities actually end up oftentimes increasing repair and regeneration in those tissues, because that's what those areas need.
Antimicrobial. Tell me about that. I wasn't familiar with that potential.
It's not talked about too much, but they are thought to have some antimicrobial properties. But we certainly still use a sterile field, and we don't rely on that for anything.
No, I was thinking more of sort of like internal, right? If you have systemic infection, or or you have some sort of smoldering type of thing, like a chronic infection, for example, that I didn't think about. Although that actually does remind me. I have a colleague of mine that's a Lyme doc that does use stem cells in some of his patients and does see benefit. And I didn't know that it was because of an antimicrobial capacity. I thought maybe from an anti-inflammatory capacity. So basically they're acting like signaling molecules, right? So, but if you're talking about, things you can do outside the United States, like umbilical cord stem cells, is it the same thing, we think, or is there a different thing that's happening with those? And why would they be, at least it seems from what I've read, that they may be better in a lot of ways than mesenchymal cells, for example, for various procedures?
So umbilical cord cells you're still getting either mesenchymal stem cells or hematopoietic stem cells. You're still just getting those two.
Right.
And so the properties are similar to the other cells that we're talking about in your body. They're just younger. They're from babies. And the thing that they can do outside of the US that we can't do here is that they can culture expand cord cells. So in the US, we do have umbilical cord cells. And even live cells are in part in some of these umbilical products that we use, but you can't grow them in a culture dish and then expand them and get 10 times or 20 times or 100 times the number. So if you're going out of the country right now, I think still makes sense if you're trying to treat a systemic disease that requires multiple doses of very high numbers of stem cells. If you're treating something like musculoskeletal pain, which is usually, it's usually a one-time injection, or maybe once a year, or, it's not something you have to do over and over again. Or the things that I'm doing, more the sex and skin stuff, where again, you're not having to do multiple injections, then I think that, staying in the US is, makes total sense.
Gotcha. So culture expanding is the main difference. So they can culture expand any type of cell. I guess depending on where they are in the world. I know there's clinics in South America, like Colombia and Mexico and Panama. And I've had patients of mine that have gone there over the years for anything from brain injuries and autistic kids. And so you're talking about real, like, systemic kinds of things. And they're typically, in that case, when they're culture expanding them, are they usually injecting them IV and then also into tissues as well? It sounds like they have a lot more to play with.
Yeah, they can do both. And of course, that's going to be, and so those are still umbilical cells, those are still mesenchymal stem cells, and they still in general are signaling cells. And then of course, there's a lot of research being done, as well as some clinical trials on other types of stem cells, like induced pluripotent stem cells, and those may actually be turning into tissue, or, embryonic stem cells, which we don't use here in the US clinically, for a number of reasons, but those actually can differentiate. So there's a lot of variations that are out there, but what we're using right now are just these signaling cells, these MSCs.
Right. And that's really, I think, a great point to make, because, my understanding was a little bit different. I thought, what I hear from, like, the doctors outside the United States is that umbilical cell stem cells are better. Right. But it doesn't sound like that's necessarily the case from your opinion. It's more just about the ability to expand them and to be able to use them in multiple different ways.
I think the truth is we don't know. No one has done, patients ask me all the time, like, what's better? Like, just getting some these cells or my own cells, and the truth is we have no idea. And especially when you look at each condition separately, we definitely don't know, because
for sure.
No one has done the head-to-head studies of these different types of cells for erectile dysfunction or for hair restoration and so you have like a bucket of information that's like, oh, these different things all seem to do work, to work pretty well, but there's no head-to-head stuff.
Yeah. it's just a very interesting field. I know it's growing very fast, and you and Harry have been doing this longer than most. It's interesting to hear you guys are now giving the option of using other stem cells or other signaling molecules, let's call them, instead of the. I know it's not a very comfortable procedure for people to get bone marrow aspirates, but I guess they still have to be under for a while for the whole injection process, I would guess, right?
Yes, we sedate. That's why the anesthesiologist was
Yes.
here. We
Yes.
sedate pretty much everyone because it is a lot of injections and it's just uncomfortable. And especially like my procedures, the scalp injections are so painful, even with like numbing cream and this and that. And so what we found is that people they just like us so much better, and I think they have better results. And I don't know if it's like if it's just a mind body thing, but I feel like
Totally.
by being sedated, by having a good experience, leaving here and feeling good about all of it, they tend to be happier and they tend to have better results. And I don't know if that's true or not, but
No, I mean, I think part of it is just the sympathetic response, right? Because if you're so clamped down and fight or flight, we know that's not a good way to heal. That's for sure. And so the best way to heal is to be as comfortable and as parasympathetic as possible. So if you're, on some ketamine and propofol, life's a dream, man.
Life's a dream.
Yeah, and going merrily down the stream, right?
And when we're doing sedation, we're not using any lidocaine, and we know lidocaine is not good for stem cells. We had minimized how much we were using it in different
Okay.
applied them differently, but lidocaine by itself is not good for stem cells. So you don't
I
want to
didn't
be
know that.
bathing an area in lidocaine and then injecting it if you can avoid it. So, there's a lot of things like that you can kind of do to try to get better outcomes. But yeah, people like being sedated, and I think it's fabulous.
So lidocaine affects stem cells. Tell me, do we know why that works or why that's the case?
I don't know why it is. I just know that several years ago, because we initially when we were doing the liposections, we were using like a tumescent lidocaine, where you essentially are bathing the area in lidocaine to get the stem cells out. And then some research came out saying this may not be the best way to do that because the lidocaine is actually harmful, and there's some other anesthetics that weren't as bad, but we ended up just stopping that way of doing it anyway.
Got it. Okay. Interesting. I didn't know that. Okay. So no lidocaine. And then what kind of anesthesia are you giving them? Are you giving them some ketamine and some propofol, or what are you guys typically doing?
Yeah, that's exactly right. Occasionally a little fentanyl if they need it. But for the most part, it's ketamine, propofol, and they're only asleep, depending on if we're using their own cells or if we're using the allogeneic cells. It may be an hour, maybe 2 or 2.5 hours that they're out. And so, we have great anesthesia guys that manage them, and it works out great.
That's great. Yeah. I mean, the ketamine might have some side benefits, right? Although we know like the psychedelic dosing is much lower than the dosing for surgery and for anesthesia, right? So, but you can always let them hang out there and like in that psychedelic realm on their way out, maybe a little bit,
We definitely have patients who are very familiar with these medications, and they're like, they'll ask for some extra ketamine and things, and we're like, well, I'm not sure we can do that in the clinic, but yeah.
We're not that kind of clinic, ladies and gentlemen. I gotcha. Yeah, but I mean that's super interesting, and I appreciate the.
Oh, there you are. Okay.
Yeah, I appreciate the perspective on the various types of stem cells, how you're using them. And so when you're doing it for sex and skin, are you typically using that in combination with PRP as well, or is that something that's not typically at the same time?
We are currently, what we're doing is if we're doing autologous and you're using your own cells, then we'll add a little PRP in there, and we'll do like a little photobiomodulation to kind of activate the PRP a bit more. But if we're doing just allogeneic, then we're not using PRP. We're trying to kind of stick with one or the other. Not that, again, it's probably fine, but it just hasn't really been studied all mixed together. And
sure.
The fewer number of variables that you have that you're introducing, the better in some of these things.
I understand. Yeah. Well, very cool. So you're a lady of many talents, sex, skin, stem cells. But one of the things that I was really interested in talking to you about as well is some of your work and some of the stuff that you're doing with ovarian aging, because I think ovarian aging is something that all of us know about on some level as a physician, but most of us don't have a good sense of. So I think I'm going to kind of keep it as an open question for you. Like, how do you think about ovarian aging as a disease, as a natural process of aging, And what is your sort of framework on how you think about it when you talk to people, or when you're approaching the topic?
First of all, I love calling it a disease. I definitely love it. It's funny because like a few years ago, I started talking about menopause as being this disease. People are
Yeah.
talking about aging as a disease, and I'm
Yeah,
like, well,
sure.
if aging is a disease, then why is menopause not a disease? And you get a lot of pushback from people because they're like, oh, it's natural and it's fine, and this is how it's supposed to be. And
Sure.
there are a lot of things that are natural that are, like heart disease is natural, cancer is natural, but they're very disruptive, and they can shorten your life, and they are, they make you weak, and menopause is the same thing. So it's only been the last few years that people have, like big researchers like the Buck Institute and some of these researchers have started talking about ovarian aging in terms of not fertility necessarily, although that's part of it,
Sure.
but in terms of if we can slow down how quickly your ovaries are aging, then you will stay healthier for longer. So as a way to improve longevity and health overall. And I will, full caveat, I'm not working with hormone patients right now. You and I talked about this earlier, but I have a hormone clinic, but I'm not seeing patients. So a lot of what I'm doing is more just researching what's out there and talking about it. But I do think it's an important thing to talk about, because people aren't talking about the fact that that your ovaries are really important. They're the pacemakers of how quickly, for women, how quickly your body is aging. Is much of it's dictated by how quickly your ovaries are aging. And we know that women who have premature ovarian failure, for instance, or have to have surgery, to take out the ovaries, they have a shorter life expectancy. They have increased risk of all kinds of diseases because they've lost their ovaries. And I think that that's not being communicated to people. And of course, you can replace hormones, and you should, especially if you have premature ovarian failure. You really do want to replace those hormones, and that helps. But I think that we're just beginning to kind of look into, like, well, is there anything else we can do besides replace the estrogen and progesterone and even testosterone that's
Sure.
lost?
Sure. Yeah. And we'll get to hormone replacement in a minute. I think that's an important topic. But I think as you think about ovarian aging, like, let's talk about the ovaries in general. Like, why do they age, in the sense of, like, why would they age faster than is there, do we think that there's, I think the first question is, like, is there like an evolutionary reason? Like, the question always becomes, like, I know a lot of other animals do not have menopause, like a lot of other mammals. Like,
Right.
I mean, and the question always becomes, like, is there an evolutionary reason for humans, adult, humans, to have this go on? And then that, I guess maybe that's the first question. Then we'll go for more.
It's a great question. Yeah, and from my reading, it's only like us and like whales. There's some orca whales
Right.
that are really the only mammals that just stop making vital hormones, halfway through their lives. And of course, in the old days,
Right.
it wasn't halfway through your life. It was like towards the end of your life, and so it wasn't that big a deal. But now it's it's age 50 is usually that's the average age of menopause for women, and so you hope that you're going to live 30 or 40 or 50 years beyond that without those hormones. I haven't seen a good reason. The only thing I've read is a potential reason is it talks about how postmenopausal women, without all those hormones kind of surging all the time and thinking about sex and being strong and active and all of that, you break them down and you make them weak, but then they're very good grandmothers and they're good caregivers.
That's awesome. I love that. It's like somebody just decided to make that up. I like that. Okay.
So, yeah. So, maybe there's some sort of like caregiving, component to it. But, if you ask me, that's a pretty ridiculous reason to go through menopause, right? Like, we could still be like strong, vibrant, sexually active, happy women and have grandchildren that we love. Like, it doesn't make any sense.
I completely agree. I was actually reading about this after I was listening to one of your recent podcasts. And one of the other theories that I read into is something called antagonistic pleiotropy. I don't know if you've heard of this, but the idea that when we're younger, we get certain traits that make it easier for us to survive, but as those same traits also make it harder for us to survive as we're older. So a common example of this is hypercholesterolemia, like familial hypercholesterolemia, is it actually gives you a survival advantage when you're younger. because more cholesterol around gives you more hormones. It gives you more the ability to be anabolic and to recover and to decrease inflammation. But we know what happens when you have familiar hyperlipidemia or hypertriglyceridemia. Like you're going to have a high risk for heart attack. But at that point, you've already had your kids and you've already passed on your genes. So I was reading something similar for menopause as well and for ovarian aging. But it's funny you mentioned that theory before, because I was just reading this article on why they think people that are gay and then because there's a genetic predisposition of being gay as well, and like why has this sort of been passed around or passed through multiple generations? Why are there? Because it doesn't really have a survival advantage, like the same kind of thing, and it's the same reasoning they gave is because gay people tend to be better caregivers. They tend to be able to they tend to have more money. They have more expendable time and they don't have anybody to take care of. So they can take care of the nephews and the nieces and the moms and the sick dads, things like that. And I was like, well, that's quite a theory. I don't know if that really works, but it's the same one we were talking.
Because you really don't. I mean, obviously, from an evolutionary standpoint, you just have to be alive long enough to have your kids and raise the kids. And so, something like menopause wouldn't ever even really become an issue because it's not being hit by natural selection. It's happening way later. But now that we're getting to a point where we're living longer, I think it should be an issue, and we should start thinking about what can we do, and that's why there's definitely some researchers out there looking at that, but it's only been in the last few years that people have really started investigating this.
Yeah, it's super interesting. So let's talk about the ovaries themselves. Why the evolutionary piece is interesting. Now, what about the ovaries makes them age faster than the rest of the body? Do we know?
So the ovaries do age about 2 to 5 times faster than any other cells or tissues in your body. And as far as why that is, we're not sure, but it does look like some of the same types of things that cause aging in other parts of the body also seem to cause some of the aging in the ovaries, apoptosis and cellular senescence and mitochondrial dysfunction and, all of these same kind of hallmarks of aging. A lot of them seem to apply to the ovaries as well. And, when women are born, there's millions of eggs in their ovaries, of these follicles. The follicles are like the little sacs that will create the egg eventually. And of course, we all know that once you start having periods, you're releasing an egg a month. And so you'd think that there'd be no way to really to stop, ovarian aging. But what you may not know, you probably do, but is that during the course of that month, you have, about 1,000 eggs that are just basically dying. They're kind of partially maturing, but they're not fully developing. They're not becoming that golden egg that gets released, and so that's the idea behind some of the therapies and things that are currently being talked about, like rapamycin and metformin and some of these drugs, as well as supplements, is there a way to slow down how many of these eggs are just being wasted, that they're just kind of prematurely either becoming apoptotic or they're just kind of being thrown away by your body? Because if we could do that, then you'd have a bigger reserve. And then, of course, by the time you hit 50, you'd still have more eggs and you could keep going. So but I think that there's a big basic gap in the knowledge really as to why are we releasing 1,000 eggs a month that we don't need? There's a lot of information we just don't know.
Yeah. I mean, it's not as bad as I guess the sperm to sperm ratios here. We're talking about, millions of sperm each time and only one makes the game. But, but men don't have the same kind of, there is something that most men don't know about, something called andropause. It does happen where men all of our hormones start going down at the age of about 30, I think, especially testosterone levels and things. And, but it's very interesting, when we're talking about, ovarian aging and the various types of modalities and longevity kinds of things that we're looking at. They kind of seem to go together, right? In the sense that a lot of the work that you're doing on the longevity side is very much involved, lifespan, health span, but also, it's also going to be correlated to ovarian aging too. So is there any literature, any research now that's being done on some of the drugs you mentioned, like rapamycin or metformin or any of those?
Oh, great question. So yeah, rapamycin is kind of the leader in the pack right now.
Okay.
There are several animal studies where they give mice specifically rapamycin, and like they'll give mice rapamycin at 8 weeks. They'll do it for a couple of months, and it will end up. Rapamycin is basically it's like an anti-growth, right? It's an mTOR inhibitor, and you're slowing down growth, and your body's like hunkering down. And so when that happens with mice, sometimes the mice will stop ovulating for a few months, but then they take away the rapamycin and they see a big increase in the quality of the eggs that are being released, in the number of little pups, little baby mice that they can have. So they see improvements in the ability, like fertility improvements specifically in those animals. And they've also done some studies looking at can we potentially reverse or delay, menopause, but they don't really have menopause, so it's kind of tricky. So, but there is a study right now going on. I think it's out of Colombia that is looking at humans and using rapamycin to try to see if we can delay ovarian aging in humans.
So they're using like premenopausal women, maybe in their 40s, or do you know the population they're using?
Yeah, I think it's 40s, women who are not wanting to have any more kids. So the ovaries are, they're not making functional eggs anymore, but they're trying to look and see. And I'm not sure what the dosing protocol is for them. So, but they're looking to see if you do a course of rapamycin, what does that do to your ovarian reserve? Does it slow down the loss of eggs over time? But the problem is there's not even a really great way to measure ovarian reserve and how quickly we are losing it.
Right.
You can do the AMH, the blood test, the Müllerian hormone blood test, and that gives you an idea. You can do an ultrasound, and you could maybe kind of take a look. But that's one of the things that they're researching is, well, what's the best way? Can we develop a better way to even see what's happening in terms of ovarian aging?
That was going to be my question. Like, how do you actually measure that in general? Or is it more looking at sort of global understanding? But I mean, it seems like you'd have to have very specific ways of measuring it. Because like you said, like every month you have all these thousands of follicles that develop. Can you see a difference in that when you're using it in these sort of medications? And does it change? And the rapamycin dosing, for longevity, I think is around people using like 6 milligrams a week or something like that. You don't have a sense of what they're using in the study, I would imagine.
Yeah, I don't know. I mean, in the animal studies, they were doing it daily for
Okay.
a month or two, and so I don't know if that's if they're replicating that in the human studies for this. But yeah, usually for the longevity, it's 6 a week, or some people are doing 12 every other week. Like we don't really know still. We're just making stuff up again.
Yeah. I mean, what's your experience been with rapamycin overall? Like personally and with any patients that you work with?
I like rapamycin. I've had some patients on it as well. I've been on it for 4 years or so at that 6 milligram a week dose, and I haven't really noticed anything positive or negative, except I get mouth sores sometimes. But I am a fan of all the research that's been done, and as you know, it's the only thing out there that has shown improvements in lifespan in every animal model that it's ever been given to. Obviously, we don't know in humans yet, but
Well, cool. So I think rapamycin and sort of the whole world of longevity is super cool. I want to get back to that in a minute, but I think sticking with ovarian aging, and then obviously the reason why we're trying to prevent ovarian aging is so that women can continue to make the hormones from the ovaries. And so I think that there's been a lot of controversy in the medical world, especially maybe more in the medical world than the alternative world, really, actually, on how hormone replacement should be done. Now, back in the 1990s and 2000s, was actually very common for people to get hormone replacement by physicians in the conventional world that you and I are trained in. But that all stopped because of something. I want you to talk us through that, and how do you think about? Let's start with hormone replacement for women first, and then we can go to men after that.
Yes. So yeah, 2002, the Women's Health Initiative was the big study that came out and basically said, oh my gosh, these hormones are giving you breast cancer and strokes and dementia and heart attacks. And, like they're causing all these problems. And so all the doctors stopped giving their patients hormone replacement therapy. And so it's been 20 years basically since that time. And as you know, shortly after this happened, some of the more like integrative doctors, naturopathic doctors, started doing these bioidentical hormones. So they were saying, I don't think the problem necessarily is hormones in general, the problem we think is the synthetic, which is not the right word, but essentially the bioidentical or non-body identical hormones. It's giving hormones that are not the same hormones, the chemical structure that's different from the ones that the patient already has.
Right.
And so these providers started, giving bioidentical progesterone and estradiol and sometimes testosterone to women, and were having good results. And there started being some other papers published, but the traditional doctors didn't like the idea of bioidentical hormones because a lot of these are compounded hormones. They're made in a compound pharmacy, and it's not FDA regulated. And there's, they think it's all like very sleazy and scammy and all of that. And so you have this big divide between the different like types of medicine. And of course, the message to patients was very confusing. I think it's really just been in the last, I would say, like I've seen a big change in the last like year or two.
Okay.
I've been doing hormones for 10 years. I started out doing bioidentical hormones, and then but still do a version of that. But in the last couple of years, you've had big names in traditional medicine. Peter Attia and like some of the urologists and OBGYNs and like traditional doctors who have looked back at the WHI and said, oh, wait, like we misinterpreted this. This actually, estrogen alone actually decreased breast cancer rate. It didn't increase it. And it was, it was these progestin, this synthetic progesterone that probably was the reason for the slight increased risk of breast cancer in the people who were getting estrogen and progestin. Even that was slight, like even that wasn't big. And so long story short, it doesn't look like, especially if you start hormones within 10 years of menopause, and especially if you're doing body identical or bioidentical hormones, progesterone and estradiol, it doesn't look like there's actually an increased risk of breast cancer. And we know also that if you do transdermal hormones versus like for estrogen versus a pill form, then there's not an increased risk of blood clots, which is, stroke, blood clots, all that. And there may be a slight increased risk of breast cancer if you're on them for a long time, but even that's pretty slight. And if you weigh that against all the benefits of hormones, for most people, I think it's still worth doing hormones.
Yeah. What about somebody that has a history of breast cancer in the family, or they have a personal history of breast cancer? Is that another? I know that's kind of a little bit of a tricky topic, but what are your thoughts there?
So, family history of breast cancer is not a contraindication. Those people do not seem to be at increased risk for further breast cancer by taking hormones. That has been studied. Certainly, if you have a personal history of breast cancer, especially if it's a hormone sensitive breast cancer, then we don't tend to give hormones, at least in the first 5 years,
right.
Because some of those people are still on estrogen blockers and things like that.
Right.
There is some interesting research actually that testosterone might be a good option in those women, testosterone therapy as a way to treat the menopause symptoms and get a lot of the benefits. But those people are, especially if they're on estrogen blockers, so they're taking like a aromatase inhibitor, so they're blocking the conversion of testosterone to estrogen because they're post cancer, they're taking like tamoxifen or something. But then there's some research that shows if you then give them testosterone, which can't get converted to estrogen because they're on a blocker, that they have a lot of the same benefits of estrogen therapy in terms of treatment of menopause symptoms and feeling better and muscle tone and osteoporosis and some of these things. So it's kind of there's early research on that, but it's kind of interesting that there may be some options with that.
So basically estrogen free and then giving them testosterone instead.
Yeah.
But I would imagine that's a little bit trickier with the dosing and making sure, like you said, I mean, they're already going to be on blockers though, right? If they have a history of this, right? So you're not going to have an issue with testosterone converting to estrogen, which can be okay for women, not so great for men all the time, as we know. So when you're thinking about hormone replacement for women, you're thinking about estrogen, you're thinking about progesterone, and you're thinking about testosterone, mostly all three together, correct?
Yeah, ideally. Now with women with testosterone, as you probably know, like in men, it's a slow degrade. Like it's like a slow slope that goes down. Starting at age 30, 35, you're just losing testosterone slowly. Same thing happens to women. So it's a slow slope for testosterone. So some people some women don't need testosterone. They feel fine. They're, especially if they're lifting weights and eating healthy and doing all those things, then maybe they don't need testosterone. And then some women, they can feel that lack of testosterone, and they really do benefit from it. Unfortunately, there's not an FDA approved testosterone for women, which we, one more soapbox you don't want to get me on probably. There's an oral form, which is not the best way to take testosterone. But aside from that, there's no injectable form or cream form or patch form or any of these things for women, even though we've known since the 1930s that testosterone is important for women, and that if you replace it, it seems to have a lot of benefits, at least in some women.
Yeah. So what do you typically use then in women that need testosterone? What is your option there? What's your go-to?
I essentially just use off-label testosterone that's prescribed for men, but we're just using it off-label. So like I like injectables. We just use about 1/10 the dose that we use for men, or creams can work well as well.
Because correct me if I'm wrong, but isn't sex drive significantly related to testosterone levels, right?
Yeah, well, women don't need sex drive. It's fine.
Talking from the sexponential lady here, I think that you're being very facetious.
Women also don't need muscles. They don't need to be able to burn fat. They don't need to be in a good mood. They don't need motivation. They don't need bone health. Like there's a lot of things that women can just do without. So they don't need testosterone.
No, just screw it. That's the reason for, bioidentical hormone replacement, right? Is that you prevent a decent amount of these things from happening at least as fast with the hormone massive decline that happens with menopause, right? So it's significant here. And so I love, no muscle, no sex drive. That's cool.
It's fine.
When it comes to like hormone replacement for men, are you doing any of this, or do you have any idea? Do you have any like major sort of takeaways or just sort of frameworks that you use when you think about this?
Yeah. Before I get to men, I want to make one point, because I know you have doctors in your audience. Which the point is that if you don't want to use compounding pharmacies, that's fine, because there are body identical, which is basically the same thing.
Yes.
Estradiol and progesterone that are available by your regular pharmacy. Like you don't. So I feel like people some patients get the wrong message. Like we have to use bioidentical. It has to be from a compounding pharmacy. And that's not true. Like these hormones are available for traditional doctors to use, as well as what other wellness doctors or whatever. Just use them. And in my other soapboxes, if you don't know about them and you're not comfortable using them, that's fine. But don't tell your patients that they're going to kill them if they, these hormones will kill you. Like just refer to someone else who knows how to use them, because there's already enough mixed messages out there that patients don't need to have you scare them anymore. That part.
No, that's a good soapbox. I appreciate you saying that. I think where I'm still learning actually, clinically myself, is during the perimenopausal period, and how well and how to optimize hormones during that. So I usually refer out to specialists that work with women in the perimenopausal time. When it's postmenopausal, that's relatively easy because everything's stable. But when things are not as stable, things can get tricky. So I 100% agree that, find somebody that does this in their office, and then has, some specialty there. So, but thank you for that. So on to men briefly, in the sense of, because, we're pretty simple, I think, when it comes down to it. But as far as hormone replacement, what is your framework? How do you approach it? If there's anything that you'd like to chat about there?
Yeah, I definitely, have treated men as well. And as you mentioned before, andropause is real and happens, and your testosterone goes down by about 1% per year, especially after age 40. There's a couple of options for men. Certainly you can boost testosterone to a degree with lifestyle. It's not as easy as they make it sound. Like I just read a study that looked at, you have to if you lose 10% of your body weight, you're only boosting testosterone by about 84. I don't know what the scale is, but essentially like that's barely enough to feel.
Sure.
So there's, but building muscle and doing other, like sleeping better, stressing less, all that will help. But if that doesn't work, then you have the option of either doing something like Clomid or enclomiphene, or testosterone. And I think part of that depends on how old you are, how healthy your testes are. But I do think, testosterone is important for men. And I think that that replacing it is a good thing unless you have contraindications, which there aren't too many. But I also think you want to stay in that healthy range. Like you don't need to be, 2 or 3 times.
Right.
healthy range. Like you still want to be in that healthy range, but you do want to be at the upper part of the range versus like the lower part.
Yeah. Yeah, I 100% agree with you. I think the challenge that I find is I do a decent amount of hormone optimization with men is that, you don't want to just do TRT, for example. You want to be looking at all your hormones. Just like with women, you want to look at your growth hormone axis. You want to look at your thyroid. You want to look at your cortisol, because all these things change as you start replacing hormones, because everything's got feedback loops here and everything works together and in sort of these anabolic catabolic processes and things like that. So I think people get sort of focused on the one thing, right? And of course, men, what are they going to focus on? They're going to focus on their testosterone level and their DHT levels, and that's what they care about. But in the end, it's not just about that; it's about the whole picture. And the growth hormone is really important, right? And we know, and for women as well, looking at the growth hormone axis can be really, really, really helpful. And either taking peptides or even low dose growth hormone, if you can get it in the U.S., which is not that easy to do, but it's a longevity tool as well. I mean, I'm sure you read the studies on growth hormone, metformin, and other kinds of things. Like we know that there probably is a longevity benefit to having more growth hormone around too. It helps you sleep better. You have less inflammation. You're able to recover more. Et cetera, et cetera. So anyway, that's I'm with you on how you're looking at. That's my soapbox for men, but it's for women as well, in the same sense that like don't just look at estrogen and progesterone and testosterone. Look at your growth hormone levels. Look at your thyroid, and and the other thing that I'm sure you also talk about is like, you don't want to just look at this in like one period of time. You have to look at over long periods of time and see how these trends go, because they're going to change. What you need is going to change, and how you're going to feel is going to change. So Amy, we're kind of running up to the end here a little bit, but I want to ask a little bit about sex-potential medicine, just in brief, because it's like, it's your thing and it's amazing. And, you didn't know that when you were in the ER, you'd be talking about sex as much as you are, but I think it'd be helpful just for the clinicians that are listening and the people that aren't docs, like, what's your framework here? I know we've talked about this in sort of pieces as we've gone through this, but I think giving like the overall framework would be awesome, just because I think people will be able to sort of access you and understand your work better, giving this larger framework, which I know you talk about.
Yeah, I have a few different ways of talking about it, but the simplest one, which is I just started talking about it this way, is when you're looking at a sexual problem with it, whether men or women, there's basically four things. There's four main ways to look at it. There's the head, which is going to be anything mental, and that the head actually in my lesson also includes brain, brain and nervous system. So anything brain, nervous system, mental health, that's head. And then there's heart. So that's obviously cardiovascular system and blood flow, which we obviously know is important for both men and women. There's hormones. I'm keeping them all H's here. You like this?
I do.
Hormones obviously very important for both as well. And then the last category is just what I call his and hers, which is the actual genitalia, the structures of the pelvic floor. And so when you have a person with a sexual problem, it could be any combination of those things. It could just be one of them. Oftentimes it's more than one, especially the head is almost always involved in some way, right? Like there's always a mental piece to whatever's happening, because there's a feedback loop that happens. But thinking about those categories is a good starting point, and then referring out to other doctors and specialists as needed. But that's kind of how I approach a person and say, okay, is this a head problem? Is it a heart problem? And is it, like where is that problem? And then kind of drilling down.
So drilling into the heart piece of this, tell me a little bit about how you think about that in like a little bit more detail, if you could.
So, heart is obviously the cardiovascular system is very important. We know ED is an early warning sign for heart disease and stroke and any kind of cardiovascular disease. But sexual dysfunction in women is the same thing. We just don't ever measure it. Like we don't have this as good tools to look at that. But with men, loss of arterial insufficiency as well as venous insufficiency is a major cause of ED. And so anything that's going to cause inflammation and cause blood vessel endothelial dysfunction, like lowering of nitric oxide, all of these types of things are going to result in sexual dysfunction. So I look at, how can you boost your cardiovascular health? And that's all the things that we know how to do: exercise and sleep well and eat well and, lose weight and all of that. And then I'm a big fan of looking at nitric oxide as well, which, I know that you know about as well. But, just looking at, are you making nitric oxide? Of course, as you get older, you make less. Are you eating foods high in nitrates that can be converted in nitric oxide?
Right.
Do you have medications or mouthwash or things like that you're taking that are preventing you from actually making nitric oxide from food? And then what are these other strategies that we can help you with, like hyperbaric oxygen or red light therapy or sunshine or exercise or mouth taping or some of these other things that can help to increase your own production?
Yeah. So nitric oxide's it's a big topic, but one thing, the study came out a little while ago. I'm sure you saw it about Viagra and dementia. And there was a decreased risk of dementia for men who took Viagra. This is not surprising for Amy or I, because this is nitric oxide and increasing blood flow. Has there been any studies in women with nitric oxide boosters, Viagra, Cialis, any of these things? Because I haven't seen any of them.
I haven't seen them either, and I have looked. In fact, I was talking to a patient yesterday about this, because he's an older gentleman, was taking a daily Viagra, but really wanted to get off of it, and I was like, do you really want to get off of it?
What are you taking it daily for, out of curiosity? For sex?
He was Cialis, but he was taking a daily
Cialis, okay.
For sexual function.
Yeah, sure.
And it was working, but he was scared of it, because he'd been told, like, it's bad for you. Medication's bad for you. Like, this is another thing that we hear, right? Medication is big pharma is bad for you. And so he was trying to get off of it. And I was like, that's fine. But I actually think of Cialis and Viagra as potentially being of this sort of like longevity drug class. Like, I don't think it's been studied enough, certainly in women, but we know that there are, improvements in cardiovascular health and post-MI and dementia, not to mention the sexual benefits, because you're keeping your nitric oxide around longer. But if you are going to get off of it, at least get on something that helps to increase nitric oxide in some other way.
Right. So, have there been any studies on women with Viagra at all? Or I
haven't seen them, but I should look again, because I haven't.
Yeah, this might be something you need to test, Amy. But obviously, we know what happens with men. It's very, very straightforward. But with women and engorgement, I don't know, and clitoral engorgement and things, it might be. I'm surprised it hasn't been looked at. But I think. Yeah,
they did look at Viagra in women for sexual problems in the past, and it was kind of like their findings were kind of equivocal, which is why they didn't approve it for women.
Makes sense.
It's not because it does increase blood flow. It does do that, but the problem is that with women, sexual function is not just blood flow. Like, there's a whole lot of, like, the mental piece is very important. There's a discordance between what's happening and there's a whole lot of other pieces that go along with that.
Yeah.
But we do know that it does, like, Viagra does increase blood flow, and it does help if that's your problem in women as well.
Interesting. Yeah, of course, women are more complicated than men in this capacity. We know this. I know men, guys that are using it for the gym, like using Cialis at low doses for extra, pump at the gym and things like that, because it's increasing blood flow again. So I think nitric oxide boosters are super interesting, and there's a number of companies that make them. I certainly look at this in the hyperbaric world as well, because at the higher doses, or the higher atmosphere doses, we actually deplete nitric oxide, and so we want to mitigate that potentially by giving nitric oxide boosters. And I'll do that in sort of like the biohacking performance side, but also in people that I know are going to be nitric oxide deficient for various reasons and conditions that would make that happen. Like, diabetes, for example, is a very common one. All right, Amy, I know we've had a couple technical difficulties, but we made it through. And my last question to you is it's a question that we ask all of our guests. I didn't give you a prompt, but you're going to be great. So the question is this: what are the 3 ways that you would suggest that you can live smarter, not harder? And Smarter, Not Harder is the name of our podcast, so that's why we call it that. So 3 ways. It could be anything. It could be sex. It could be skin. It could be how not to treat priapism in the ER, whatever you think might be good. But just 3 global things that either you do personally that you think would be great, or that people can consider. The floor is yours. Whatever you think.
Wow, that's a hard one. Okay, 3 ways. I do have to advocate for more sex. I feel like like more quality sex. Like, maybe not, like, it's not about the number as much as the quality. At least for women, that actually is true. Sure. So more sex, make it a priority.
Less semen retention.
Yes.
I know that's one of your favorites.
Oh my gosh, yes.
That's a soapbox. Okay, quick on this.
Don't get me started.
Okay.
Number 2, I think this is a lame one, but I think prioritizing sleep is very important. And I think that a lot of us don't do that. People who, the hustle culture, especially,
Yes.
I think doesn't do that. So prioritize sleep, stop hustling, just go to bed.
Yeah.
And then number 3, I don't know if this falls into this category, but I have recently fallen in love with cold plunges. And I really do feel like they're amazing, like for mental health. I don't even know about the physical benefits, but like for mental benefits, I cannot advocate for them enough. So a big fan. And so go get yourself a cold bathtub or a lake.
Okay. So more sex, more sleep, less semen retention with more sex, more sleep. And the third would being more cold.
More cold. Yep.
Gotcha.
I think that's it. Yeah. And I think I like the addition of the semen retention, which basically means less believing the nonsense. Like the 4th one is less, don't believe the nonsense.
Right. I mean, piecing out the nonsense is hard, but we have an expert here. So I appreciate that, Amy. Well, thank you for hopping on. I think the last thing I want to chat with you about, because I forgot, is your company, your longevity company that's working on amazing supplements, and tell us a little bit about that before we go.
Yeah. So it's called Human Optimization Project, or HOP. You can find us at hopbox.life. And we are a longevity focused supplement company and education platform. So we're trying to make education around this subject really easy for for people who are not medical and not scientific, by making, we have these little characters, and we talk about the hallmarks of aging, but they're like these little like cartoon characters. And we have a whole lot of education in there about like why you're actually aging, why you're getting diseases, what you can do about it that's very practical, as well as we have some supplements. So check out hotbox.life if you want to try them.
So is it like a box that you get like as a subscription, or how does the whole process work?
Yeah, it's a box like this. I actually was using this for my stand here for my computer. And
Nice.
then it's like these little twice daily packs that have there's 19 ingredients in each pack. You take one in the morning, one at night, and they're basically, we formulate them just to be the things that you're not going to generally get enough of in food that have a good evidence or some evidence for promoting longevity and health. So we're assuming that you already have a healthy diet. We want you to get most of your nutrients from food, but it's things that you're not going to get enough of in food that are going to be helping support stem cell function and mitochondrial function, and decreasing senescent cells, and all of these different things that we know make us age faster.
Awesome. Well, I know you were doing some of the initial artwork with them a couple of years ago, and showing us at all, I think on maybe at A4M or something. So I'm excited for you and your colleagues and your partners in crime over there. Amy, where can people find more about you and what you're doing, and your socials, your links, those kinds of things, please?
So on Instagram, I'm pretty active. It's Dr. Amy B. Killen.
She
Dr.
is.
Amy B. Killen. And I try to do too much rapping or dancing these days. And then I also have a website, which is dramykillen.com. I have multiple websites, but you can get to all of them from that website.
You have the greatest name for like anybody. Like if you ever were like a movie star, you wouldn't have to change it. Amy B. Killen, you got it.
I know. I wish I had more like artistic talents that I could take advantage of.
Oh man. Thanks so much for being here, Amy. This has been great. I really appreciate your time and effort, and you can go back to doing some additional stem cell pea shots and hair.
Thank you, Scott.
Okay. Take care. Thank you so much for tuning into this episode of the Smarter Not Harder podcast with Dr. Amy Killen. We hope you learned something. I certainly did. Sex, stem cells, longevity, ovarian aging, all very cool stuff. Don't forget to like and subscribe to our podcast so you don't miss an episode. Please share with your friends and colleagues. And we hope to see you next time on the Smarter Not Harder podcast, where we answer and we give 1 cent solutions to $64,000 questions. Take care.